Welcome everyone and good morning. In today's class, we are going to be talking about internalizing problems during the adolescent years. Now, we've spent time talking about externalizing problems in the previous few classes. And externalizing problems are when we take problems, distress, and we express them outwardly. We act out, we bully others. Internalizing problems are when we take distress and we reflect them inwardly. And so when we're thinking about internalizing problems, we're talking about things like anxiety, depression, and suicide. By far the most common internalizing problem is depression. It is the most common internalizing problem during the adolescent years, with approximately 15% of adolescents experiencing depression before the age of 18. So again, quite common. Now, when we think about depression, we typically think about feeling sad, feeling blue, feeling just generally down in the dumps. And we all have felt that from time to time. But depression is more than just feeling sad, feeling blue, feeling just down in the dumps and you don't want to get out of bed. Depression involves emotional symptoms like feeling sad and cognitive symptoms like feeling pessimistic, feeling hopeless. It also involves motivational symptoms, not wanting to do anything, being apathetic. Being bored is also a symptom of depression. And beyond emotional and cognitive symptoms and motivational symptoms, we see that physical symptoms often are indicators of depression. So changes in appetite, for example, changes in sleep pattern, and just generally feeling lethargic, that can also be a symptom of depression. So it's more than just feeling sad and feeling blue, and it's more than feeling sad and feeling blue for one day. Again, like I said, every now and then we feel sad, we feel down. You get a bad test grade back, you break up with someone, you're gonna feel sad. That's normal. But depression is feeling sad and demonstrating other symptoms for a long period of time. So we have to distinguish between depressed mood, which is common. Again, every now and then we feel sad, and depression as a disorder, which is long-term and involves multiple symptoms. Now, when we think about depression, there are some very interesting gender differences that we see. If we look at depression among boys and girls, in childhood, boys have higher rates of depression. They're way up here with their depression. And girls have lower rates of depression. But as we eke towards adolescence, boys and girls actually meet, and girls surpass boys in their rates of depression. And this surpassing, where girls' depression rates skyrocket, happens right at puberty. So prior to adolescence, prior to puberty, boys are more likely to be depressed than girls. But right at puberty, we see a reversal in this trend, where girls are much more likely to be depressed than their male counterparts. And this advantage in depression, having higher rates of depression for girls, continues well into adulthood. So when we look at female adolescents and female adults compared to their male counterparts, they're 2 times more likely to be depressed. And they're going to maintain that 2 times more likely rate until very, very old age. Now, since we know that gender differences in depression emerge in puberty, a lot of people have placed the blame on hormones, for example. There must be something going on with the hormones that leads girls to be depressed. If puberty is truly the marker, and it's not chronological age or elementary school versus middle school, it's puberty as the marker, then hormones must play a role. There's very little research, however, to support that hormones are the primary reason why girls are more depressed than their male counterparts. So what I want us to do now is speculate Why are there gender differences? Why are girls more likely to be depressed than their male counterparts? So one thing is, we think about puberty. Girls go through puberty, they move away from that ideal body type, that reed, thin, very narrow body type. They gain more fat relative to muscle. That's going to lead to self-consciousness and body dissatisfaction, which in turn we know are linked to depressive symptoms. Also, girls do something very different when they're in a depressed mood or when they encounter a stressor. They ruminate, just like Kim said. What is rumination? It's thinking about something over and over and over again, over-analyzing a situation. So let's look at what a boy would do in response to a stressor and what a girl would do in response to a stressor. You experience a breakup. A girl is likely to sit there and analyze over and over again what went wrong in the relationship. Why did they break up with that person? Why did they get dumped? They overanalyze it over and over again, thinking about different scenarios, trying to find reasons for the breakup. Boys, on the other hand, maybe they'll think about it for a second, but then they go do something else. They distract themselves. They go play Xbox. They hang out with their friends. So girls are overanalyzing problems. They're ruminating about problems. And when you ruminate, you're not moving away from those negative feelings. You're letting those negative feelings sit and stew with you. So rumination is a big liability for girls. And often girls don't ruminate alone. They ruminate with someone else. They co-ruminate, meaning they call up a friend, they go to a friend's house, and they, with their friend, overanalyze things to death. They talk for hours and hours about the breakup. That is not healthy behavior. So that kind of reaction to a stressor, ruminating versus distracting and moving on, is a significant liability for girls. And we know from evidence that girls are more sensitive to relationships. On average, there's some research that indicates that girls value relationships more than boys. So when we get to adolescence and we start bullying one another, and boys fight by actually physically fighting, and girls fight by disrupting friendships, that disruption in a friendship hurts even more. Another factor that wasn't mentioned, those are all wonderful factors, is that puberty is a stressful event in and of itself. Think back to your puberty experiences. Not the sunniest of days, I'm sure. Puberty is difficult, and girls on average go through puberty earlier than their male counterparts. And so they're going through this stressful time when they may not have the cognitive and psychological resources necessary to cope with it. And often for many young girls, puberty co-occurs with other stressors, like the transition from elementary school to middle school and changes in peer groups. So we know that girls on average experience more stressors. They have changes in their body satisfaction with lower levels of body satisfaction, more self-consciousness. We also know that they ruminate over problems. And they're sensitive to relationships. And so when relationships are hurt via things like relational aggression, that serves as a major vulnerability for depression. So we know there are gender differences and certain reasons why girls are more likely to be depressed. Now, for many people who are depressed, they have thoughts of suicide. And this is called suicide ideation. So suicide ideation is just a fancy term for thinking about killing oneself. Not surprisingly, girls have higher rates of suicide ideation during the adolescent years, with about 20% of girls saying they have thought about killing themselves, and about 10 to 12% of adolescent boys saying they've thought about killing themselves. So girls have higher rates of ideation or thinking about suicide. They also have higher rates of actual attempts. When we look at suicide attempts, approximately 10% of adolescent girls have attempted suicide, whereas we only see about 5 to 6% of adolescent boys ever attempting. Now, how does this translate into actual suicide completion rates? Even though girls are higher in ideation and attempts, boys are higher in completion. they're more likely to actually commit suicide. Now, this is because boys choose different methods. Girls are more likely to attempt suicide by taking prescription pills, for example. Boys are more likely to choose a lethal method, like a handgun, which has a higher success rate. Now, all this sounds really depressing and sad, but I have some good news for you guys. When we look at historical trends, we actually see that rates of suicide ideation, rates of suicide attempts, and rates of completed suicide are actually on the decline. So since the 1990s, we've actually seen a smaller number of adolescents think about, attempt, and complete suicide. Why have we seen this historical trend? Well, in many ways, we've gotten better at treating adolescent depression. We've also seen a massive influx in antidepressants, which have been very effective for young people. So even though rates of ideation, attempts, and completion are not where we want them to be, there is some uplifting news in that these things are generally on the decline. We also know that the groups that have the highest rates of suicide, so what ethnic or racial groups are more likely to commit suicide? Native Americans and Alaskan Natives have the highest rates of suicide. So we actually see a lot of differences as a function of ethnicity. Now, some people think about suicide, they have suicide ideation, but they actually don't make an attempt and they don't make a completed attempt. Some of them engage in non-suicidal self-injury, NSSI. Non-suicidal self-injury is deliberately harming yourself via cutting or burning. So you've probably heard the term before, being a cutter. That's someone who's engaging in non-suicidal self-injury. We don't know a lot about non-suicidal self-injury. There's not a lot of good data on this behavior among adolescents. We do know some estimates put 25% as the rate of adolescents who've tried it at least once. So 1 in 4 adolescents at one time have deliberately hurt themselves. That's an alarming number. That said, we still don't know enough about non-suicidal self-injury, but we do know a lot about suicide. And one thing we know a great deal about are the risk factors for suicide attempts. So who is more likely to attempt suicide? Now, it's really important to understand the risk factors, because if we know the risk factors, then we can effectively intervene to prevent attempts. So it's one way where we can prevent and intervene and reduce the number of suicide attempts and in turn the number of fatalities. So there are a number of risk factors that we've seen in the literature. One of them is having a psychological disorder. So if you have a psychological disorder, you are at an increased risk of attempting suicide. The psychological disorders most commonly linked with suicide are depression and substance abuse. So having a psychological disorder is a risk. Another risk is having a family member who has attempted or committed suicide. So the family also can serve as a risk factor. Beyond having a family history, we know that families characterized by a lot of conflict, a lot of discord, where people are fighting constantly with one another, that can serve as a risk factor as well. So if you live in a family that is very, very troubled and very, very dysfunctional, you are at a higher risk of attempting suicide. We also know that young people who are rejected by their parents, whose parents don't want to be involved in their lives, they are at a higher risk of attempting suicide as well. Finally, another risk factor that we've seen in the literature is stress. So if you experience a significantly stressful event, especially in the domains of sexuality and achievement, you are at a greater risk of attempting suicide. So you flunk a class, you don't get into the college of your dreams, that can serve as a risk factor for attempting suicide. But many young people don't ever develop depression, don't ever develop suicide. Many young people go through adolescence relatively unscathed. So how can we understand exactly what makes someone likely to develop depression, to develop suicidal ideation? We know there are some risk factors for suicide attempts, but it would be nice to have a theoretical model that explains it all to us. Luckily, we do have that model. It's called the Dioceses stress model. The Dioceses stress model explains why some people experience a lot of stressors but don't develop any problems, and why someone experiences one stressor and develops a debilitating psychological problem. So in the Dioceses stress model, we need two things to happen. You'll see it's a hyphenated theory. We need a diathesis, we need a predisposition, and we need a stressor, a stressful event. We need these things to co-occur, to happen together, to develop a psychological problem. Now, this model has been used primarily to explain why some people develop depression. Other people have used it to look at other internalizing problems like anxiety and suicide ideation. But thinking about depression, you need a predisposition first and foremost. A predisposition could be a genetic predisposition, for example, or it could be a cognitive style. If the way you think about the world is in terms of pessimism, the glass is always half empty, it's never half full for you, or you feel hopeless, you don't see the future as being very bright, that cognitive style serves as a predisposing factor for depression. So we have a predisposition. That predisposition has to interact with a stressor or a trigger to allow depression to manifest. What are the certain stressors that are likely to lead to depression during the adolescent years? Well, family problems, again, are a big issue. If you live in a family characterized by lots of fighting, lots of discord, you are more likely to become depressed. So family problems serve as a stressor or a trigger. We also know, especially important for the adolescent years, that being unpopular is a stressor or a trigger. Being a rejected youth, being someone who gets picked on, who gets bullied, that can serve as a stressor that triggers depression. But we need both of these things to happen. We need the predisposition and we need the stressful event that triggers depression. So many people have predispositions. They have a genetic predisposition, they have a cognitive style that I would call maladaptive, but they never develop depression. That's because they didn't have the stressful event that triggered depression. And we know many people who are stressed. They experience a number of stressors at work, at home, at school, with friends. They have lots of stressful things in their lives, but they never develop depression. And that's because they don't have a predisposition. So we need both of these things to interact together to demonstrate the psychological disorder. So many young people are what we would call resilient. They experience lots of stressors, lots of stressful events, and never, despite all of this adversity, develop depression. Now, how do we know what makes someone resilient? Many people who are resilient possess unique internal and external factors, and they're also better at coping with stress. We'll talk more about that in a minute, but let's talk about coping with stress in general. We know that about 50% of adolescents say they struggle with coping with stress from either home or from school. 50% of adolescents say they're having trouble dealing. but 50% are actually doing okay. So there's a lot of variability in how we respond to stress. One thing you should know is that it's harder to cope with stress the more stressors you have. So again, you have stress at home, you have stress at school, you have stress with your peer group, you have stress at work, you have a terrible boss who's breathing down your neck, you just broke up with your boyfriend or girlfriend. Having all of those stressors is difficult to overcome. So essentially, the more, not the merrier in this case. The more stressors you have, the more difficult it is to be resilient. So now that we have that out of the way, let's talk about the people who are resilient, who despite lots of stress, despite significant adversity, they are demonstrating healthy and normal functioning. The people who are likely to thrive in the face of stress, who are likely to be resilient, are those who possess certain internal resources. Now, when I say internal resources, I'm really thinking about a few things in particular. Youth who have high self-esteem cope with stress better, cope with adversity better. Youth who have high levels of self-competence. They feel like they can get things done, that they believe in themselves. Those youth cope with stress better. We also know that intelligence is this protective factor in the face of stress as well. So when you have some of these internal resources, you're better equipped, essentially, to deal with stress. What about some external resources, things that reside outside of you that help you deal with stress? There is one external factor that we've identified in the psychological literature as being especially important, and this is social support. Social support, feeling like people are there for you. That if you need someone, they're going to be there for you, whether it's a shoulder to cry on or they're going to give you some practical help. Having people in your lives you can go to is a robust protective factor. Across many, many studies, we see that people who have higher levels of social support, meaning they have more people they can go to and a higher quality of support from those people do better psychologically. Lower levels of depression, lower levels of perceived stress, lower levels of loneliness. So having people you can go to is particularly important in being resilient. That said, there is one caveat to this discussion. Social support is good on average most of the time. I'm a big advocate of social support. I think having people you can rely on and go to is wonderful, with one exception. If when you are eliciting social support, you are engaging in co-rumination, then that's problematic. So oftentimes we have friends that we go to and we vent and complain about something, and we vent and complain and overanalyze things over and over and over again. Well, it feels good to have that friend there for you, to feel supported. But there comes a point of diminishing returns, where if you keep ruminating, you're going to lose the benefits of social support. And we know this is particularly true for adolescent girls. So social support is usually uniformly good unless it devolves into rumination and co-rumination. So we've talked about internal, external factors that help us fight off stress, that help us be resilient. Now I want to talk about specific coping strategies that help us fight off stress. How many people in response to finals decide to maybe exercise, watch a movie, talk with friends? I think those are common ways that we deal with stress. So the ways that we heard some of you articulate your coping responses, we heard a lot of kind of take the bull by the horns. Tackle finals head on. Develop a plan for how I'm going to study, how I'm going to get this done. We would say that this is a primary control coping strategy. A primary control coping strategy. Some people call them problem-focused coping strategies. Essentially, when you're faced with the stressor, you try to deal with that stressful event directly. You take it head on. You develop a plan for facing and defeating that stressor. Now, some of you raised your hands when I said, how often do you, in the face of finals, in the face of stress, talk to friends, exercise, maybe eat inordinate amounts of chocolate, watch TV? Many of you raised your hands. That's a valid way of coping too. We would call that a secondary control coping technique. You're not really trying to change the stressor or tackle it head on. You're trying to change your emotional response to the stressor. You're lowering your level of arousal. You're getting to a more comfortable place. You're cooling down a little bit so you're not so keyed up and so tense. Now, my recommendation is that when there's a stressor you can control, when you can do something about the stressor, like study for finals, you do that. You engage in primary control coping or problem-focused coping. You tackle the thing head on. You grab the bull by the horns. But if there's a stressor you can't do anything about, let's say you're with a roommate and you can't change your roommate, it's too late in the semester, and you just have to deal with this person, trying to be problem-focused is frustrating because you actually can't change the problem. So when there's a problem you can't change, like having a roommate you don't like, being in a section of a course you don't like and it's too late to drop, it's bad to engage in primary control coping because you are going to get frustrated. It's better to engage in secondary control coping. Try to make yourself feel better, essentially. Change your emotions around the stressor. So one of the keys to coping with stress is being able to appropriately match the coping technique necessary with the stressor we're facing. So if it's something we can't control, we should try to tackle it head on. We see better outcomes for people when they enact that coping strategy. If it's something we can't control, there's nothing we can do about it, it is what it is essentially, then we need to engage in secondary control coping. So the match between the stressors is very, very important. So we're going to wrap up here today with a few take-home messages. Again, today we talked about internalizing problems. This is where we take problems and distress and turn them inward. This is very different than externalizing problems. Externalizing problems are we take distress and problems and reflect them outwardly. We're aggressive, we act out. By far the most common internalizing problem is depression, with approximately 15% of adolescents demonstrating depression before the age of 18. Now we know depression is more than just feeling blue. It involves a lot of symptoms, and it involves those symptoms over time. Every now and then we get down. That's normal. But when it is chronic, when it is persistent, that's when we know there is a serious problem. We also know there are gender differences in depression, with girls more likely to demonstrate depression compared to their male counterparts, especially after puberty. That's that marker that marks the shift in depressive trajectories, where girls demonstrate more depressed mood and more depressed symptoms. We know lots of reasons why that occurs, and for some youth who are depressed, they think about suicide. They attempt suicide. And we know that girls are more likely to think about, to attempt suicide compared to their male counterparts. But boys are more likely to complete suicide. Now, suicide is one of the leading causes of death among young people. But again, there is some positive news that attempts of suicide, thinking about suicide, and actual suicide rates are declining. Some good news here. For every 100,000 adolescents, 4.5 of them die from suicide. It is not an extremely high number, but is high enough to cause some alarm. And how do we fix this problem? How do we deal with these young people who are having thoughts of suicide, who may attempt suicide? We think about the factors that put them at risk, and we try to intervene. We also know that some young people go through adolescence relatively unscathed. They face a lot of stressors in their daily lives, but they never manifest a disturbance. This may be in part because they don't have a predisposition. This may be in part because they possess certain internal and external resources, or it may be that they're just really good at coping with stress. So as you guys prepare for the final in this class, what I would recommend is to put down the Ben & Jerry's and crack the books. Thank you, everyone. Have a good day.